Okay, everyone,
Okay.
let's give a warm welcome to Professor Antonio Ruffo, urologist and andrologist in Napoli. He's our main key opinion leader in the prostate ablation, which is a new discipline for us, our consultant and proctor. And today Antonia, I suppose you're going to discuss about cases. I'm not sure how many you want to discuss about. And then probably the reason we have so many people on here is because there are many questions.
Sure, that would be nice to answer to all these questions.
So Stephanie, feel free I will pass on the microphone to you, Stephanie, and feel free to coordinate this meeting in the way you want.
Okay. Thank you for the judge to give a brief introduction about the professor Ruffo. So welcome to IMAA International Microwave Ablation Academy webinar session on microwave ablation in prostate. I'm Stephanie from Kenyo Medical, and I will be the host today. So, okay, just it's the time. So now, without further ado, so let's extend a welcome to Professor Antonio Ruffo. Okay, Professor, the floor is yours. Okay.
Okay. Thank you, everyone, for just listening to what I will say. I will try not to be too boring. I'm a man of operating theater. I met with George. He came in my clinic and we were showing how we started using this procedure that I'm very, very happy about. Because I had a long experience with transperineal ablation using laser technology. So I started this procedure back 2016-17, so it's nearly 8-9 years ago. And I was trained by a radiologist that was doing this procedure using this diode laser. Then I gave up for a while, and then Resume came with the technology with the vapor, and so having these skills back, I just upgraded the technique. So I used another device called the Ecolaser Elesta. It's a diode laser using 4 different fibers working together. So regarding that technique, I have a long years experience. But now with microwaves, I'm very excited because the procedure is basically the same. It just performed with the transperineal approach, and I will show you. And but it's so fast and effective. The energy that and the reduction of the prostatic volume that we just achieving. I mean, I don't have too much long-term data with this patient, with our patient, but I mean, they're all fine, and we're gonna continue following them, in order to assess all the data regarding the voiding improvement and prostatic volume reduction, and so we're gonna publish this data. So we're still collecting that. So I will have a very short presentation because I would like to share with you, ideas and questions. So I think it's a bit more interesting than just me talking about BPH and long, boring presentation. So I will now share and I will put my presentation. Can you see the screen?
Not yet.
Wait.
Not yet.
That's the other thing. I'm okay as surgeon, but with technology, I'm very stupid. Can you see it?
No, not yet. Not yet.
Can you see? No?
No.
Okay, so I'll show you. Okay. Okay. Can you see now?
Yes. Yeah, we
Yes.
can see it.
Okay, so it won't be too long presentation. And I will talk about, the transperineal microwave ablation for BPH. I mean, I personally did just 2 cases with low-grade prostate cancer, because that's another field that we're going to treat, because it's very interesting, even that point, that we can treat so many no aggressive lesion 6 prostate cancer when you have a single node with this minimal invasive technique. So this is very interesting. And I think it will be a changing in the idea how to treat this less aggressive prostate cancer, because nowadays, in Italy, but I think everywhere in the world, we have so many robots, Da Vinci, Hugo, all the Chinese new devices, they're coming like crazy. Of course, surgeon, they push it a little bit to perform surgery. They have a machine, they have technology, they have expertise, so they try to use it as much as they can. But I think so many cases, even like old patients with so many comorbidities, so with, as I said, low-grade prostate cancer, there's no need to undergo to aggressive surgery, but there is room for this minimal invasive technique to treat these patients without any effective side effect, nothing too dangerous for their health. So we know how the microwave works. When we have food, we put food inside microwave, and these waves, they just move the molecules of water, and then it just goes and it gives an increase of the temperature. We know that when we have fever, our temperature goes high. It's a response of our body to kill bacteria, and viruses. It's the same like when this energy goes up to a certain kind of temperature, unfortunately, the cells, they're going to die. And that's what's going to happen when we do a microwave ablation. The temperature just goes up, and the water, molecules, they move, and then they just increase the temperature, leading to a necrosis, a coagulative necrosis of the tissues. It's different than the activity that normally are used in urology, with the laser technology, that most of the time we use vaporization of the tissues. So in this case, we don't care too much about, doing a vaporization, reducing the tissues in the moment, but we care about giving this coagulative necrosis. So the tissues in the following months after the procedure is going to shrink, because with the reduction of the cells that they're just being killed. This is just, the little animation moving. This is a nice video that George gave me. So you can see how the antenna goes. In this case, it's inside the liver, and it goes precisely under ultrasound check, precisely inside the node. So this, energy just destroys the tissues, giving this coagulation necrosis, and it just gives an instantaneous results. Can you hear me?
Yes.
Yes,
Okay.
we can.
Okay, you see on the left how the energy is released by the antenna. It goes laterally, like creating a small area that it just treats the tissues. So these are some of the, the indication: liver, thyroids, kidneys, lung, uterus. And now we're starting with the prostate. The one we're using is the tight tip antenna that,
Professor,
yes.
sorry to interrupt you. We are not seeing a presentation right now.
Okay.
Maybe you minimized, or yeah.
Can you see now?
Can you try sharing it again, or pulling up the window?
Okay, so float it. Okay, wait. Can you see now?
Yes, we are good.
Sorry. I mean, I didn't say anything too intelligent. I'm sorry, this is my Napolitan humor.
It's all good.
So I was saying that we use, can you see now, George?
Yes, very good.
So this is the device, the machine is small, you can carry around, and it's good. And this is the antenna, the tight tip, the one we're using, that it gives us the best performance to treat prostate. Because the thing is, the prostate, it's located in a very, specific area. It's dangerous because it just is next to the rectum, the bladder neck, and the sphincters, and of course there are nerves that they're very important for erection, ejaculation. So it's a very delicate tissues that we don't want to, of course, damage when we perform a procedure, especially because patients, they come from this procedure, they're well informed. Now patients, they know what they're going for. They come to me, they say, Antonio, I want this and that. With the internet, it's good and it's bad in a way. So they study a lot, they know what they want. So you cannot do something to them they did not expect, especially regarding ejaculation preservation. That's an important topic we'll discuss later. So the antenna is like this. It has a 3 millimeters active tip. I've been using the 5 millimeters one as well. They both work good. So I didn't have any problem with both antenna. And of course, inside the antenna is cooled down with water. So it never releases any kind of energy inside the tissues. So when you are precisely inside the prostate, in this case, you know that you're treating that certain area that I will show you, but the next tissues, the temperature is normal because it's water cooled. So we are pretty sure we are not going to create any damage to the local tissues. This is the one, as I said, I'm using. That is the 16 gauge, 5 millimeters, and the length, it can be from 10, 13, 15 centimeters. We had some problems because I was using this procedure with the large volume prostate. I went up to 250 cc, so very large volume prostate. So in these cases, I need a longer antenna in order to reach the base of the prostate, or when you have a nice big median lobe, you need to have a long antenna. If not, you cannot reach it and you cannot give a good treatment to patients. So regarding the energy, we're working on 30 watts, and the timing of the power released in the zone, I'm saying not making experiment because I don't like the word, but we're just changing a little bit because we noticed in the first cases we were doing that we placed the antenna and we stayed there for 1 minute. Okay, so working on 30 watts, we achieved an area of like 2 centimeter length per almost 1 centimeter long. So you can see on the image, it will be A and B. So 1 centimeter per 2 centimeter. The antenna, it does not work in front, just 1, 2 millimeters maximum. So it's good because you go precisely near the structure. Imagine when you are inside the prostate, you know that even if you're next to the bladder neck, sphincter area, seminal vesicles, you know that in front of the antenna, you're not going to release any energy. So it gives you the chance to go directly inside the lobe with a super precision. You can be precise on the millimeters. This is very important when you want to preserve all the sexual function and when you want to treat a small prostate cancer. Imagine you have a 5, 6, 7 millimeters node. You go precisely inside the node and then you do the ablation. Then I tried a different way to stay less time inside the lobe. Like I was staying 10 seconds, because even like that, even staying just 10 seconds, the tissues that you treat, that you ablate, is like 1.5 centimeter per 5 millimeters. And doing a pullback, it's important because you treat first the base of the prostate, and then you pull back slowly the antenna in order to treat the distal part of the prostate. And the advantages of the technique is not just for of course, the effectiveness of the machine or the device, so this energy, but you go under ultrasound control. I know my friends, they use red zoom, they love it, but as I say always, I cannot see inside the prostate when you do the release of the vapor energy, so you don't know where you're going. So it's okay, it works, but I prefer going in this way and the ultrasound control precisely, and I know where to treat. Because I always say to my patients, every prostate is different. Every man has a prostate, and every prostate is different from the others. Even if the volume is the same, some patients you have a big reduction of the volume, some patients less. Why? Because it's the structure of the prostate. It can be more fibrotic, less fibrotic, more water, less water. So with the same amount of energy, with the same size, you're going to experience a different results. That's because of every prostate is different. So in this way, I check live how the antennas work tissues.
Hi, sorry to interrupt you. We can't see the slide.
Okay, again.
Yeah.
No, interrupt me every time. Sorry. I don't know why it goes. Can you see now?
Not yet.
Yes, yes.
No, we see it.
Yes.
We see it. It's on the chart.
Can you see it now?
Yeah, just maximize if you can.
Okay.
Thank you.
So this is the thing. So the indication, of course, I'm not going to talk about other organs. I mean, it's interesting for kidneys as well. When you have a small renal masses, it has indication like any other minimally invasive technique like cryotherapy or laser or radiofrequency. I'm sure, I don't have experience with that, so I'm not going to talk about that, but it's very interesting to treat these kind of small nodes. For BPH, I would say you can treat any volume. It doesn't matter. It's more than 30 ml. You treat prostate, they give like avoiding problems. Even if you have a small median lobe and the prostate volume in general is 20, 15 ml, you're just going to treat that. You treat the median lobe, you're going to have an improvement on the avoiding symptoms. So contraindication, of course, will be when patients has BPH and prostate cancer. So it's good to investigate patients first with PSA, with the digital rectal examination. And when you are like doubt about the situation, I always perform a 3 Tesla MRI. And so I'm pretty sure, even for medical legal issues, in Italy now it's becoming crazy. Patients that just come with a lawyer and they sue you. So it's always good, not just for the patient, of course, but even to protect yourself, to be 100% sure that the patient doesn't have problems, so you can undergo to the procedure without problems. Regarding urethral stricture, this is another important point. I do urethral surgery reconstruction, so I know that so many times we treat patients for BPH, but the problem is the urethral stricture. So always do a urethral cystoscopy to patients in order to check first the urethra, because that will be like a failure of procedure. Because even if you have a reduction of the prostate volume, but you still have the urethral stricture, patient won't have a good voiding, so it won't be good to do it. And if the stricture is too tight, too small, of course you cannot put the catheter before the procedure and after. And then patients with neurogenic bladder and these kind of problems, because unfortunately, if the bladder is not working properly, even if you reduce the prostate volume, you're not going to have a reduction and the patient cannot void. Persistent, administration of anticoagulants, I left this, but personally, I do it because I do it in local anesthesia. So I treat patients, even if they do anticoagulant, antiplatelet therapy. For us, is no any contraindication for the procedure. So why I love the procedure? This is a small point that I send to the patients that contact me, for this procedure. They ask me, what about the anesthesia? It can be performed in local anesthesia. As urologists, it's great to give a treatments that you can do it in local anesthesia. Normally, for BPH treatment, you need to do it in general anesthesia or spinal epidural anesthesia. So it's okay, but with some kind of patient, it's better to perform it in local anesthesia. Still, because you can just discharge them after 2 hours. Patients after the procedure, I normally send them back home. They go home after 2-3 hours. So for them, it's a real minimally invasive concept of treating BPH. I put 10 minutes procedure, but it depends on the prostate. Like, mainly we treat like we do 100 joule of energy each ml of prostate. So imagine a guy with 100 ml prostate, we normally do 10,000 joule. That is released, let's say, in 4 or 5 minutes. Working on 30 watts, it's like 1,800 joule per minute. So it's pretty fast procedure. In 5 minutes, the procedure, the ablation is done. Bleeding. I mean, I did not experience, I'm not talking about bleeding when you see a little bit of blood on the perineum or in the catheter during the procedure, you know what I mean? I don't call that bleeding. So normally patients does not need to put three-way Dufour catheter, for washing the bladder. There's no need. So we just put a normal 16 Charrier Foley catheter after the procedure. As I said, we don't need to suspend anticoagulant or antiplatelet therapy. And this is another important point, because lots of colleagues, they contact me, even with the different energy I was using, as I said, with laser, but always transperineal approach. They're asking me, do you treat large volume prostate? Do you treat median lobe? I say, yes. In the beginning, for me, when I had a large volume prostate or median lobe, I was performing enucleation with thulium. I was doing TULEP. And then I was doing ablation for average small size prostate. But then I realized that you can do any kind of volume. It's just a matter of where you insert the antenna and the timing of procedure. So the larger is the volume, more energy we're going to release. And with the median lobe is the same. We treat the median lobe first, that actually in this case is the part of prostate that gives the majority of the symptoms, and then we treat the lateral lobes. Ejaculation. I left 80%, because all the colleagues, they talk about minimal invasive technique, can be iTind, red zoom, any kind of minimal invasive technique. They say 100% preservation ejaculation. I don't believe in medicine you can see 100% to any patient. It's no mathematics. And seriously, let's say with our numbers, I would say that the preservation is around 80% of patients. Because the more energy you release in the prostate, the less are the chances to preserve ejaculation, So you cannot predict that too much. I mean, that's why it's important, good counseling with the patients, in my opinion, because patients that is very motivated, younger patients with younger companion, and they want to preserve ejaculation, so I release less energy. I tell them, okay, we're going to treat just the central part of the prostate, try to give less energy. You're going to have a smaller reduction of the volume, but the percentage, that can be even higher, than 80%. So if patients agrees with this, they say, okay, I don't mind, I won't avoid, better, I just won't quit with drugs, but ejaculation for me is very important. So I just cut down a little bit with the energy. So it's a matter of compromising with patients and with the results. With patients, they don't mind about ejaculation. I can perform better ablation. I can go in different spots of the prostate, treating more tissues, more energy, and of course, you're going to have a bigger reduction of volume. I tried to put a nice video, George, but sorry. This is a smaller antenna. We can see we insert inside the prostate lobe. This median lobe was already treated. And now we can see the insertion of the antenna inside the tissues.
Is this a patient you had treated before, Antonio?
Yeah, it was done. I think we did it in May.
Okay.
And we are inside the prostatic lobe. You can see how fast the tissues become white, hyperechogenic. That's what I love, This is the tissues that is treated. So when we see the tissues, prostatic tissue, that it changes color, we know this is the area that is just been treated. So precisely, and now I'm using a guide so I can go with the needle precisely inside the lobe. This is, of course, like a average size prostate. And I put another small video with the larger volume prostate. As I said, we see live where actually the energy is going and how the prostate is reacting, because it's not always the same. Some prostate, you see it changes color fast, some other prostate less. So I mean, now when I have these patients, as I say, they want to preserve ejaculation, I try to treat just the central part of the organ. Then we pull back the antenna, we just rotate the probe, and we go in the other lobe. We can see the balloon of the catheter. And I try to stay, let's say, half centimeter from the bladder neck, 1 centimeter. I mean, now the vision, I mean, it's upside down because the rectum is above. So the rectum is in the upper part. So it's like you see the prostate upside down. This prostate, as I said, is no very large volume. And we have other videos with the bigger prostate. As I said, it's important. What I love about the procedure, patient is not bleeding, is awake. And, I feel like I always tell these patients, we are not treating any cancer. In this case, is BPH. I don't want to risk nothing. I don't want even 1% of chances, of complication. And this is the end of the procedure. And we're going to see in the axial view as well. So we can see all the tissues that was treated. Before I was treating the apex of the prostate as well. Before I was going here on the apex. But then, with any kind of treatments we do for prostate, we know if we preserve at least 1 centimeter, 1.5 centimeter of tissues on the prostatic apex, we have a better chances to preserve ejaculation. So I used to do it a lot, but now I'm not doing it anymore. I try to leave untouched the apex. And in this case, I'm just going on the little part here on the apex. You see the catheter, in the middle part. This is the axial view. You see now that the part that is whitish, is completely ablated, the lobe. We can see that, the normal prostatic tissues on the periphery, it was not touched. So we didn't need to treat it. We just ablated all the lobe. And this, of course, in the following months, it will go to a reduction. The reduction of the prostate, in the beginning, I was checking patients after 1 month, then 3 months, then 6 months. I have follow-up. I always speak now as I said, with the microwaves, I don't have long-term data. So we have like patients now 7 months, the first patients. And in the reduction in just increases, because with the old technique of prostatic thermal ablation, I was checking the final data 1 year. So I always say patients, the best reduction, it will start at 6 months to 1 year. This is just a short video that, of course, I have other short clips that I can show. This patient had a 200 cc prostate. I previously already treated the median lobe, and I was going on the lateral lobe. You can see the volume is much larger than the other. And you can see here, that before I already treated this area. So that's why I want to show. Because we see from here to here, there are 6 centimeters tissues. And it's normal that if you insert the antenna here where you see it, it's not going to treat more than 1 centimeter. So you need to do at least other 2 ablation in the same spot, in the same lobe. So that's why I say that you don't have any problem with the volume. So the complications, what they can be, in my opinion, the worst complication is the patient has to put catheter again. What it means? I mean, this technique, it just has one, let's say, problem that it's important to speak with the patient about. The catheter, it needs to stay in place for, let's say, 4 or 5 days. With other techniques, I know that you can remove catheter after 1 day, 2 days, but with the ablation, it's normal because after the ablation, you have edema of the prostate, so the prostate just compresses the prostatic urethra. So patient, if you remove it in 1 2 days, is not able to void. So the worst scenario is that patient, after the 4 days, 5 days that he remove catheter, he would just try, he would just have problem, not be able to void, and we need to put catheter back again. And this happens with patients that they already had like bladder dysfunction, a patient with the indwelling catheter for months or years, elderly patients. Of course, they have a bladder that is not working properly. So with this patient, it's important to tell them before, in advance, that maybe the catheter needs to stay longer. So this is the only complication that actually I need, because the pain, you can control it with painkiller, steroids. The same with infection, we always give antibiotics to the patients. Bleeding, as I say, the hematuria, it's something like very easy to control. We never need, and never ever need to take patients again in the operating theater for reduced surgery or hemostasis or stuff like this. All the management of patients is like medical. Patient goes home, you need to check him. Of course, I check them often in the office, but they come, they get checked, and then they go home. We don't need to just, it never happens to any patients that he had problems that we have to take him back to the operating theater or to the clinic. So I would say that, all the different border symptoms of any kind of procedure that, is normal. And but even these, it depends, it changes between patients. So regarding this, the main issues, maybe I talk about Italian patients, we are like soft people, it's, oh, doctors, how many days do I need to keep catheter? And will I lose the ejaculation? These are the main issues for Italian patients, So all the rest, we control it pretty easy, without any problem.
The presentation is down again. If you can.
Okay, now it was finished. But did they see the video?
Okay, good, no problem.
Do I show the video that we took with the
Yes.
the video maker?
Mhm.
Okay, so I played that one. Just a second. I don't know why it's doing this. Oh, just 1 second. Okay. I know, look, my desktop is crazy. Okay, can you see the presentation?
Yeah, we can see the window.
Okay, this is the presentation, the video we took. I removed the audio. This is the longer antenna we use that is the best to treat the prostate. You see, we did the local anesthesia on the perineum with a small needle, so patient doesn't not even feel the needle that we do the anesthesia on the periprostatic block. What I love about procedure, that you perform procedure and there's no one drop of blood. As urologists, we know when we treat prostate, it's always bleeding, water everywhere. You saw, George, we can just put gloves. It's like office-based procedure. You don't even need to be completely scrubbed because it's everything done by small need antenna insertion in the level of the perineum.
Yes, like in an outpatient clinic.
Yeah, it's like a prostate biopsy. It's exactly the same for the patient, it's exactly the same.
Professor, can you talk a little bit about the equipment besides the antenna? Like I saw a question from one of your colleagues about the probe that you're using. Can you talk a little bit about the probe, the guider, stepper, which companies? I mean, without the feeling of advertising, but what you consider useful for your practice.
No, you're right. I forgot about this. It's very important. It's mandatory. This endorectal probe with the B plan. It's not the normal probe we use for, let's say, prostate ultrasound, but it has a linear part and a convex part. Because in order to see the prostate like this, you need to have a linear part on the endorectal probe. And there are some companies that produce it. I mean, the one I'm using here, it's related to the machine, as I said, I was using. But there are different companies. They use it. They produce the same probe. I mean, it's not something you find too easy. No, all the company they produce it, but you can find it online. But this is mandatory in order to. I mean, if you are an expert, skills urologist, you can use even the normal, endorectal. But to have this vision, you need exactly that probe. This is we can see, on the screen, the temperature of the antenna is cold, so we don't have any release of temperature just outside the treating the point that we know we're releasing energy. We're working on 30 watts. We did some patient with 40 watts, is even faster. I think 30 watts is a good compromising, not to have too many bother symptoms. Because if you burn too much tissues, too much necrosis, it will stay inside the prostate, and patients will annoy you longer, because he will have more bother symptoms. And but this is mandatory. The antenna, the probe, it's the only thing you need with the machine, with microwaves.
And as far as the guider or the stepper?
I mean, for the guide, the first patient we did, now we're using a guide that so it makes you easier to go precisely where you want to go. Because imagine you have let's say here, there's a small prostate cancer. If you go with the free hands, it's okay to go inside the lobe like this. This is a large volume prostate. You can go with the free hands. But if you want to go more precisely, I think you need a guide on the side, like this one I'm using. This one was used for the laser fibers. And then we made not this one, we made another one that makes everything easier. It makes everything easier and much faster because you do insertion, because this guide, they are like, each hole it's half centimeter. So you know precisely where you want to go. Because you can see on the screen, the centimeters. So if you put in the first hole, you will be half centimeter. And then you go up each half centimeter. As I said, it's always nice to see a clean surgical field like this. It's completely, for me, it's a game-changing technique, for BPH. That I personally use all the techniques. I change it from one technique to another, and now I stopped with this one because, in my opinion, is the best in terms not just of effectiveness. Because people they do vaporization, enucleation, they say, with the tool polyp you reduce all the prostate. Yes, but which cost, which terms, and you don't send patients after 2 hours back home without bleeding. It's completely different things. Because even when I tell you, I do urethral surgery. I can interrupt. Okay. Can you see me?
Yes, clearly.
Yes.
I would say, when you do normal transurethral surgery, you can be a master, but you still stay inside urethra for some times. So you still have from 5, 6, 7% of urethral stricture after the procedure. You can have bleeding, And if you do big numbers as a surgeon, you start to see the complication, because you do 100 prostate, 5-6 patients, they will have urethral stricture. 5-6 patients, they need to go back to the clinic. You know what I mean? And if you start to see on the big numbers, you start to see the complications. And but another important point, in my opinion, as urologists, we always think that it's normal to undergo medical treatment for BPH. Patients that come to you, their problems, you give them tablets. And then if the tablets don't work, you change tablets. And then after years, you do surgery. I think it's wrong algorithm, because, if you have a problem, if you're normal, you should not take medication for prostate. You should avoid normally. So the day you start to have problems, it means that you have something to treat. And even the bladder, we don't think about the bladder health at all. It's something we don't really see, but the bladder starts to stress. First becomes, of course, larger, it compensates the BPH, but then after a while, you start to discover and to have bladder dysfunction. So I think, in my opinion, you need to save your bladder and the function of the bladder. So as soon as you start to have prostatic issues, you can tell patients, listen, there's two ways. One way, you go with medical therapy. The other way, you do something to reduce the adenoma, and so you don't undergo medical treatments. It's still hard, for the medical, for the colleagues to understand this. And finally, people, they starting to realize that you can, because this is a minimal invasive procedure, you can start to just suggest patients, even when they are they're young, in their 50s, before they start to experience problems, with the bladder neck sclerosis or bladder dysfunction. So and if you work on a younger bladder, if patient is younger and you treat the prostate with very small energy, it's gonna have a good results, because it's not all the urinary tract is not compromised. So it's something, whenever I talk about these minimal invasive techniques, I say to my colleagues, to the patients, wait, you don't have to see this technique just against prostatectomy, ablation, enucleation. You start to check the medical therapy. We start to have problems regarding sexual function with the therapy. So it's important to understand that in the moment you start to experience voiding problems, patients need to be treated, and in the best way, in a minimal invasive way. So this is my, let's say, goal, in order to understand better how to treat patients, not just the one they need to undergo like serious surgery, but even the one they undergo medical therapy. Because it happens, so many men, they say, doctors, I don't want to get finasteride, I don't want to get alpha blockers. You understand? It's something that we give for granted. You say, oh, don't worry, it's not cancer, it's BPH, take this and that. But patients, they don't want to feel like sick taking a tablets every day. Especially some men, they're young, or some other men, even older, they already take lots of drugs. So they ask, as a doctor, I already take 10 tablets for diabetes, for the pressure, for everything. I don't want to take more tablets. So this is the thing regarding, our management. So when you have these techniques, I see them easy to perform, and the day you learn how to do it, you're gonna love it, because it's so easy to perform, fast, and effective. So it's a really great tool in the hands of urologists that he wants, just promote new technology. And I think it's a serious procedure. I'm happy to start to have more experience with prostate cancer, because as I said, I didn't do too many cases with the laser ablation. That, as I said, is a similar technique. But now I'm just motivated to start to do it, because that's another game-changing procedure. Treating a prostate cancer in local anesthesia, in a day surgery, and even still, so many colleagues, they say, oh, but you're treating patients that should be on active surveillance. and it's not aggressive. It's just Gleason 6. Well, if I had the Gleason 6 cancer, I would prefer to burn it with ablation, and just stay without that cancer, to live with the idea and with the stress that one day it can just, grow. I mean, if I do it in local anesthesia, 2 hours I'm home. Personally, on my prostate, I will do that, and I will feel free to go home and zero problem with the erection. I didn't say that, I forgot, but it's one of the most important part. With ejaculation, I will stay on 80% preservation. Regarding erection, I mean, we don't experience any problem. We stay pretty in a safe zone. We don't stay outside of the prostate capsula where the nerves they run. So regarding erection, we are not going to have any problems. And I mean, you still need to be careful. You have rectum there, you have bladder neck, you have sphincters. I mean, you need to be confident with the anatomy, at least with ultrasound. That's why red zoom is done by many doctors, because many doctors they don't know how to do a good ultrasound. What I mean? So it's like they find it easier to go like a cystoscopy and just release the vapor inside the prostatic urethra. But still, I see lots of. I was using red zoom 5 years ago, and I mean, I didn't get the results I'm getting with this transperineal approach, because as I said, I can go wherever, and the checkout. It depends on the shape of the prostate, is larger, longer, with the median lobe. You just give it a tailoring therapy, on the shape of the prostate. That's why, I find it very, very, it's just exciting, to do easy procedure. I mean, for me, it's easy because I don't see blood. I don't get wet. I don't have to do, all the complex things when you do 200 grams OLEP, TULEP, if colleagues have experience. I mean, you need to go on the top level to say, okay, I don't get problems with OLEP and TULEP. They are doctors, the masters. I was doing huge prostate with OLEP and TULEP, but there is no, I cannot compare the amount of stress I don't have, doing this procedure. And I'm really happy and satisfied with our first results. If anyone has any questions.
Very good, Antonio. I'm sure there's going to be a lot of questions. Before Stephanie takes over, I just want to mention one thing and be clear to the big crowd that we have. The indications that we have are for BPH. I totally understand that you have ideas, and these ideas are exactly what allows us to further develop our technology and go to bigger lengths. But just for everyone to know that the indications on our IFU is for BPH.
Yeah.
Thank you.
Yes, of course.
I have a question.
Yes.
How do you compare this technique to laser ablation?
I mean, I say that the technique is exactly the same. Laser ablation, as I said, I started many years ago, and I did maybe 300-400 cases with the microwaves. Unfortunately, I don't have this experience at the moment, and because of course I started before with the other procedure. But I think it's exactly the same, the indication and the technique, But with this antenna, that it's, in my opinion, it's what I noticed. It's less body symptoms, and regarding the way the laser can just do, necrosis and burn the tissues, and the antenna, because it works on 30 or 40 watt, it's much faster. And I find it that, of course, I don't. When I do a technique, I'm like this. I don't say, "Oh, this is shit. It's bad. This is good." I mean, I'm honest person, so I see the difference. If you're good doing transperineal laser ablation on the prostate, it's very similar to the microwaves. But then why I switch to this technique? Because it's faster. So I have patients with the local anesthesia, and I prefer working faster, and I can treat precisely. We do one antenna is much more. I don't know. I like the idea that you go there faster and less bother symptoms. But it's similar because it's the transperineal approach that is different than the normal transurethral approach. But I think that with the cases I'm doing now, I'm happy about the results. And of course, I can tell you, let's say for next summer, that there will be 100 more patients done, so I can be more sure about the results. But let's say this preliminary data that I'm having, I'm very happy. I think if you are a good surgeon and skilled, you use this device. I mean, if you give the machine in the hands of a good surgeon, you're gonna get results. And I mean, I'm happy, but I don't know yet the big difference. But at the moment, in my preliminary data, it's faster, no bleeding, and less bother symptoms. This is my first impressions.
Okay. Thank you.
Welcome.
Professor, I would like to add some support to your presentation and your experience from a perspective of the interventional radiologist who has been performing ablative therapies for more than 10 years. I don't have exact experience on microwave ablation on prostate BPH like you, but I have experience on other organs like thyroid, liver, kidney, and so on. Especially in the thyroid, our last 10-year experience on thyroid ablations, like benign thyroid nodules, and the special technique of that we call moving shot technique seems to be pretty effective on the prostate theoretically, as you explained. Because for the last 5 years, I've been trying to tell my urologist friends that this is the future of the BPH treatment. Okay, definitely. Of course, it is hard for me as a radiologist to convince them to send me the patients, but for you are lucky that you were trained by an experienced radiologist and you are performing it by yourself. And I would like to ask you if you have published your experience or other authors have published this data of microwave ablation. And my second question, as I asked before, would be that do you perform routinely multiparametric MRI to all patients before this planning? Thank you. Sorry, but we can't hear you.
Can you hear me? I don't know why my computer. Can you hear me now? Hello?
Yes, we do. Yes, we do.
Okay, I start from the last question. What I said, I don't perform to all patients MRI. I mean, I'm going to start because we're doing some, we want to do some study in order to understand why some prostate, they reduce more and some other less, as I said. So MRI can be a good tool, to just understand this. But I do MRI with patients with, when PSA, it's a little bit higher, or when I feel some kind of suspect, or, I do that, but not all patients. Regarding the experience, as I said, I say thank you to this radiologist. We work in the same clinic like 10 years ago, and this guy is so skilled guy, I'm sure like you, he was doing everything, and with this ablation. So I learned the technique by him, and all urologists, they were laughing at me, it was funny, because I was, this thermal ablation is useless, And because in the beginning I was using a laser that it was in the clinic, it was not like this eco laser that did big marketing regarding that. I was not promoting it too much because it was like a normal diode laser. But then I just gained a good experience thanks to this good radiologist that he just told me how to use it and everything. And it was good with the experience of urologists to upgrade some things, For example, I don't say that, I don't want to bring myself bad luck. I never had an abscess of the prostate that some people, they keep asking me, because of course not just the technical part, we put some experiences in the medical urology, how to avoid infection, treatment, how to follow up patients. But the technique I learned, it was by this radiologist, and that is the same technique. And you told me the technique for the thyroids. moving. I'm doing the same now with the prostate. And it's much, much faster. It's like you stay 10 seconds in place in the same spot, and then you keep moving like you do with the thyroids. But still, I'm not sure about telling what is better, to stay in one place and doing 1 minute, then pull back, or just doing, multiple spots. I'm just collecting different groups, but at the moment I don't have the data, enough patient to tell you which is better, of the two technique of the microwaves. You understand?
I can tell you hypothetically, not like you theoretically, but hypothetically, I will tell you that it doesn't matter as soon as you are doing it under the imaging guidance, live imaging guidance, and if you keep your needle and ablation zone away from the urethra, the capsule, or other organs, it'll be totally safe in both techniques, I think.
Yeah, for sure.
Can I have a question?
Yes.
As far as I can understand, you don't make any discrimination between BPH nodules and stromal hyperplasia. So, do you target TZ as a whole, or could it be a better idea to target the BPH nodules?
Yeah, it would be a good idea. I mean, now I'm treating, as I said, the patient with large volume prostate, and we just noticing the reduction of the prostate. I mean, my idea was to perform MRI or elastosonography of the prostate in order to understand the fibrosis of the organ. I was checking patients like this in order to understand if it was more fibrotic or less fibrotic tissue in the prostate.
So, can you make a comparison with laser ablation in terms of efficacy? I mean, all minimally invasive procedures seem to have a minor morbidity, but less efficacy compared to the traditional treatments like HOLEP, surgery, or other things. But what is the efficacy? I mean, currently we have two transperineal modalities. One is laser, and the second, hopefully, is going to be microwave. So, based on your initial experience, can you make a comparison with laser?
The thing is, I mean, this is a smart question. The thing is, as I said, I don't have long-term data with microwaves, but with my experience, I noticed that I was using, let's say, 100 joule each gram, each cc of prostate. So I'm just translating the same, let's say, experience on the microwaves. That, of course, working on 30 watt, it means that in 1 minute I release 1,800 joule. That is, so it's just faster.
Yeah, it's
but
much faster.
Yeah, but the coagulation, I mean, coagulative necrosis, it should be similar. I think with microwaves, it should be less aggressive in terms of, because when I do the laser, sometimes you can smell the smoke, and I felt like I had a little bit of more border symptoms with the laser. The traditional techniques, as I said, I perform them, and I mean, it's not that I don't do. If I have a bladder neck sclerosis, so I have with volume, I don't have a problem, but with some kind of patients, I still do transurethral techniques, even if I just reduce that a lot. But as I tell patients, it's normal. If you do enucleation, you are a skilled urologist, you do OLEP, TULEP, you will remove all the adenoma. But what I tell patients, I say, listen, this is not a game. I mean, it's not like gambling, between colleagues who reduces more the prostate. This is more things that so many times we show to Congress. Our patients, they're not Congress, you know what I mean? Because you go to Congress, they always compare green light, TULEP, OLEP, this, that. What I tell patients, you come here and you will improve your voiding. You will stay 2 hours in the clinic and you won't risk nothing. That's the main thing. Because I was doing TULEP. Even if you're good, you can have a little bit of bleeding. The patient needs to stay 1-2 nights after the procedure. Of course, the reduction in prostate volume is higher when you do, even if with the normal TURP. When you're skilled urologist, you can do a fantastic job with the normal TURP. And but the point that I focus is local anesthesia, no bleeding, you don't need to interrupt drugs, zero major complications. So I just mix all these together. I say, okay, doesn't matter. I don't do the top of the reduction in the volume, but I'm doing something for the patients. It can be end ejaculation as well. There's few things that they are good points for this technique. But still, as I said, last Tuesday I did 4 patients, 3 microwaves. One I did normal TURP. It was a colleague. He had completely destroyed bladder with the diverticular blood and neck sclerosis. I just did the normal bipolar TURP. So because that was the right indication for the patient. You know what I mean?
Thank you.
Welcome.
May I ask a question?
Yes.
Thank you very much for your presentation. How long do you let the patient have the pollen in the urethra after the procedure? This is my first question. And the other one is, have you compared before and after your flow parameters to see how the patient improved?
Yeah, sure. No, we put the catheter, 3-way Foley catheter during the procedure with continuous irrigation. So we just cool down the urethra in order to give less bother symptoms to the patient. And then we keep the catheter, the same catheter, 16 Sharir for, let's say, 4 or 5 days. That was the main thing. Because we don't have too many problems regarding as I said, the urethra. And sorry, what was the second question?
So have you performed before and after the procedures the uroflow parameters?
Yeah. We just with all these patients we're collecting, we're just doing Euroflow, ultrasound, IPSS questionnaire, quality of life, and we're just collecting data. So we do have some Euroflow results. I think I have in my screen. I don't know where it is. But as I said, the reduction, I just have not too many patients, 6 months, 7 months follow-up. So I'm just waiting, for the, let's say, at least a big group of patients with at least 6 months follow-up. We're just, collecting data. But
do patients feel urination comfort after the procedures in a couple of days or weeks?
I will really, honestly, they need a few weeks. The first weeks, I care that patient can void without need to put catheter again. I tell them what experience at the beginning, nocturia. They need to wake up a few times and they void more times. But this is normal because the ablated tissue stays inside the prostate. I tell them it's like a burn. You need to wait that your immune system is going there and you start to have reduction of all the dead tissues, even with the small hematuria they experience in the following weeks. But it's nothing medically too important, you understand? It's like you can manage that with the anti-inflammatory, with fans, with the medical drugs. I mean, personally, if you want to compare, that would be the only, let's say, issues with these ablations in general. It can be red zoom, transperineal laser ablation, microwave ablation, that the tissues is not removed in the same moment or like a normal transurethral treatments. So that tissues needs to be removed by your body. And that's the problem. When you have necrosis, you have inflammation, and you can have pain. So that's something you need to manage with steroids, painkillers, and it depends on patients as well. It depends how much energy release. That's the most important part.
Okay, thank you very much. Thank you.
You're welcome.
Okay. Thank you, everyone.
Did I touch something? Can you hear me?
Yes, we do hear you.
Sorry, it's, I don't know, my computer. I was listening to Stephanie, but then I could not hear.
Yeah, but we didn't also lost her. We lost her voice also.
Okay.
Hi.
She's back.
Hi. Can you hear me?
Yeah, sure.
Hi. Yeah. Thank you, Professor Ruffo. Thank you for your intelligent sharing with us. Thank you very much. And today we are running off time today, so we are drawing to a close. Thank you very much. Thank you for everyone for your time and participation today. So please stay tuned for our events webinar from us in future. So thank you very much.
Oh, thank you.
So, okay. Bye-bye, everyone.